Okay, afternoon everybody. Welcome to the session this afternoon. I'm Associate Professor Chris Baker, and to begin I'd just like to perform Welcome to Country. Most people I presume know roughly who I am, but I'm Yagara on my mother's side and Warringah as well. So Yagara is the country that we are on today, and it sits between the Pine River to the south, Logan River to the south, Pine River to the north, out to the Bay Islands and to the range near Toowoomba. So I'd like to just welcome everybody here to the meeting, welcome everybody to country, and acknowledge traditional owners past, present and emerging. And we'll commence the session on endophthalmitis for general ophthalmologists. I'll hand over to Phoebe. Thank you.
All right, thank you. I'm Phoebe Moore. I am an ophthalmologist in Tamworth. So it is my very great pleasure to welcome everybody to Endophthalmitis for general ophthalmologists. This is a topic very dear to my heart as I am a general ophthalmologist with a subspecialty interest in retinal uveitis. We have 6 talks throughout this afternoon. We're going to have 1 question at the end of each talk, but what I would encourage you to do is have the conference app open to the live Q&A session, and would love it if everybody could send questions through as the talks are going on so that we can have some really robust discussion time at the end. We'll allow 30 minutes at the end of the session to answer any questions and hopefully generate some really good interactive discussion. So please, as we go forward, submit your questions through the app. But without further ado, it's my very great privilege to introduce our first speaker, Associate Professor Penny Allen, who is a Melbourne-based VR surgeon who runs the Victorian Endophthalmitis Registry and is one of the most published clinicians in endophthalmitis management. She is going to present to us about current Australian data and state of the science.
Thanks, Phoebe and Chris. And I'd like to thank the organising committee. I think that all of us are well aware that it's really wonderful to be in Brisbane. Not only is it lovely to be in the Sunshine State, but it's great to be meeting up with all our colleagues again from interstate. And I want to thank Rosie for organising this session. So I just wanted to start with a little bit of perspective. And we're all aware that endophthalmitis prophylaxis and treatment has evolved very greatly over time. But I think it is worth bearing in mind that not that long ago, between the 1920s and 1940s, the rate after cataract surgery was 2%. And we have to bear in mind that that 2% means a painful blinding of the eye after surgery, as there was no effective treatment. In the 40s, this reduced a little, but it wasn't until the 50s that there was a significant reduction to 0.3%. And in 1974, the rate was reported as 0.086%. And at that time, the reduction was attributed to meticulous aseptic technique, an improvement in the trauma of surgery, and pre-operative antibiotic prophylaxis using a mixture of chloramphenicol and polymyxin and erythromycin. In the 1970s, Golan Payman started investigating the use of intravitreal antibiotics after a group of animals that he was operating on had very devastating endophthalmitis. And it was that work that led to the gold standard of broad-spectrum intravitreal antibiotics that we use today. In the 70s also, Forster initiated diagnostic vitrectomy and the use of intravitreal antibiotics after diagnostic vitrectomy. And it was those two and that selection of work that led to really the only randomised controlled trial in endophthalmitis that has been run and published, the endophthalmitis vitrectomy study. And you will remember that the intravitreal antibiotics used in the endophthalmitis vitrectomy study, which was for cases of cataract and intraocular lens within 6 weeks of surgery, was vancomycin and amikacin. And As people became aware that amikacin was linked with macular toxicity, and ceftazidime, it was realised, had a very similar spectrum of action, that ceftazidime was used instead. So where are we now? And I just wanted to talk about our registry and how we've been collecting cases of endophthalmitis that present to the Royal Victorian Eye and Ear Hospital now for over 20 years. And it's when we look at a graph like this that I think it is useful to just see the changes in the spectrum of disease. And we can see that the blue line is cases after cataract surgery, and the green line is cases after intravitreal injection. And so the registry has enabled us to track changes in precipitating factors of disease. It's enabled us to also identify some other small trends in disease, and it's only by identifying these trends and looking at the micro data that comes from these cases that we can then initiate better treatment. And I just wanted to give you just a little breakdown, and we've got, the post-cataract and intraocular lens micro results on the left and the intravitreal injection micro results on the right. And, it's very useful to know what we are culturing for these patients to ensure that our broad spectrum antibiotics are indeed appropriate. So what are the challenges? Okay, so we know what the precipitating factors are. We have broad spectrum antibiotics. We know that treating people promptly is really important. Well, the problem is we still have some really bad outcomes. And Emil Kernawan looked at our cases of streptococcal endophthalmitis in 2018. And, this slide makes for pretty depressing reading. They present with poor vision, the vast majority of them hand movements or perception of light, but final visual acuity less than 660 in 77%. 25% were enucleated or eviscerated. We're able to identify some associations with poor outcome, poor presenting visual acuity, no view of the fundus, so, hence heavy or dense vitritis, a large number of organisms on gram stain, more intravitreal injections because obviously the disease is severe and they're not responding to treatment, and a heavy growth on culture, and in particular strep identified on gram stain. And if you look at the associations with enucleation and evisceration, once again, poor presenting visual acuity and particular non-viridans streptococci are identified. I also wanted to talk about our other big challenge, Klebsiella endogenous endophthalmitis. And there's been a well-documented increase in the cases in Southeast Asia, and initially in Victoria, and we also collaborated with Sydney on a paper where really all of the patients were of Asian background or had Asian travel. But now we have seen patients that have had no travel to Asia and are non-Asian background. The problem is that these patients do very badly. They often have bilateral involvement, they present with subretinal abscesses, and those final 6 visual acuities here in the bottom row, light perception in both eyes, an enucleation, and only moderate visual outcomes in the other 3 eyes. So we're clearly not winning the battle. So how do we overcome the challenge of poor outcomes? And that's what hopefully we're going to be able to shed some light on during this session. Clearly, being able to identify more causative microorganisms. We don't have positive culture in 100% of cases, and certainly at the eye and ear, it sits in the mid 60 to 67 sort of % of cases. And so, you know, obviously there's an evolution in identification of microorganisms, and we need to think about how we use that in our practice. I've always been worried that there are some patients that might be at risk of endophthalmitis. There's been a number of papers looking at aqueous culture at the end of cataract surgery. And, you know, some of these papers are quite old, going back to extra cap days. Some of them are, you know, more recent. And yet those percentages of, you know, 2 to 29% culture positivity in the aqueous at the end of a cataract surgery, well, not all those people are getting endophthalmitis. So what is it about the people that do? And we certainly know that, you know, diabetics are at risk, but what is it, are there other people that have, you know, innate problems in their phagocytosis? And Rosie and I have tried to look at this in some patients. Unfortunately, we haven't identified what the problem is, but I still feel, I have a gut feeling that there are some people that are at risk of endophthalmitis. What about biomarkers of poor outcome? And there's quite a bit of animal work, and there are some human studies, most of them small series of under 50 patients. But you know, there are definitely cytokines and growth factors that are associated with poor visual outcomes. And I think we need to do more work looking at this and then using that to try to work out how we modulate the immune response to infection and hopefully then end up with better visual acuity outcomes. So I wanted to conclude by saying that the registry aids us to understand trends in disease. Microculture and sensitivity ensures that we use the appropriate antibiotics, but we do need to improve our identification of microorganisms. We need to better understand the immune response in the eye, and we need to learn to modulate that immune response to try to get better outcomes for our patients. We have a lot of people that have worked on endophthalmitis over the years with Rosie and myself at the Eye and Ear, and in particular Rowan, Essex, and there's a list of people up here, and you know, I'm very grateful for their help, and we hope to just make that list longer, really. The members of the VR unit have always been very supportive, and we are supported by a great RedCap data capture, electronic data capture tool, and that's helped us to analyse this data and hopefully come up with better solutions. Thanks.
Thanks very much, Penny. Look, what we'll do in terms of the questions is after the end of each talk, we'll have one question from here on the stage, and then hopefully at the end we'll have enough time for questions from the audience, and they can be uploaded via the app. But Penny, the question for you is, in terms of our database and where it is at the moment, notwithstanding limitations, are we at a point where we can start to predict trends in terms of organisms and rates of infections? Do we have enough data in it for that?
Well, we've got over 1,100 patients sort of on the database over 20 years. I don't know that we we certainly knew that when intravitreal injections were taking off, then obviously we would have an increase. I haven't mentioned intracameral antibiotics, but we've published on that, and we know that that drop in cataract surgery came with the introduction of intracameral antibiotics. I think that there's going to be a lot more treatment of disease with intravitreal injections, and so we can predict that there will be, you know, more cases because we're going to be treating geographic atrophy as well. The more aggressive gram-positive cultures that we get with the intravitreal injection endophthalmitis was perhaps not something that we predicted, but we're now well aware of. and unfortunately it is more aggressive disease and the visual outcomes are not as good.
Thank you so much. Our next speaker is Dr. Rowan Morani, who is a retinal specialist working at Concord Hospital, who has published extensively on endophthalmitis, and he is going to talk about evidence for prevention in intravitreal injections. Can we all welcome him?
Thanks very much. So I'm talking about endophthalmitis prophylaxis regarding intravitreal injections. We put together a review paper looking at this and found an overall rate of about 1 out of every 3,500 injections. If you think about where the infection can come from, it's really one of 4 sources. It can be the patient's own flora, it can come from the air, it can come from contaminated needles or other instruments, or contaminated drug. There are a number of measures we can look at to possibly reduce the risk of endophthalmitis. We haven't got time to talk about every single factor today, so I've picked out 3 things to talk about. The first one is surgical face masks. In 2011, Colin McCannell brought to our attention that patients undergoing intravitreal injections were 3 times more likely to have streptococcal endophthalmitis compared with patients having cataract surgery, where surgical face masks were worn by the ophthalmologist. And other groups confirmed this finding, and as Penny was saying, the outcomes are much worse. It's a much more aggressive disease. They present earlier. They're more likely to end up enucleated. So in 2012, the college guidelines were updated to include a recommendation that we should wear masks when doing our intravitreal injections. This was a retrospective series from Sydney Eye Hospital that Matt Simonovich put together, and this was a time period before those recommendations, and you can see that the rate of streptococcal endophthalmitis was about 4 times higher compared with cataract surgery during that time period. But if you look post-2012, that rate came right down, and we think that's due to the wearing of surgical face masks while doing injections. We know from experimental studies that there is aerosol contamination of the surgical field, and wearing a mask or not talking can certainly reduce that risk. This was a PAT survey from the ASRS in 2019, so pre-pandemic. And what it shows is that there is quite a bit of hesitance in the US regarding wearing face masks by the ophthalmologists. So you can see in that survey, less than 40% wore masks. So if we look at this pre-pandemic era, the post-injection endophthalmitis study group found that the group where face masks were worn did have a lower rate of endophthalmitis, didn't reach statistical significance, but what is interesting is that there were no cases of oral flora-related endophthalmitis when face masks were worn compared with the group where face masks weren't worn. But everything changed in March of 2020, and not only have all the doctors started wearing masks, but the patients have been wearing masks too. So how has this changed things? Well, this study was by the same group, and they looked at a time period straddling just before and just after the onset of the pandemic. And they found a reduced risk of endophthalmitis when universal masking was occurring. Didn't quite reach statistical significance, but the reduced rate of culture-positive cases did reach significance. Experimental studies have shown that there is leakage of air from the top of patient face masks, and in this study, the ear loop masks fared the worst. So what can we do about this? We can really do 3 things to stop the patient's exhaust fumes going up to their eyes, and we know that those exhaust fumes might be carrying bacteria. We can tape the top edge of the mask. We can use an adhesive surgical drape. I know many of us have stopped using drapes, but that could be an option here. Or you could simply take the patient's mask off. This is an example of a patient wearing a face mask, and you can see there's quite a decent gap there. You can, in some cases, achieve a reasonable seal with tape. Other times, even with taping, a small gap can remain. So that is something to think about. Second thing I'd like to talk about is antisepsis, and this is really critical when it comes to reducing the risk of endophthalmitis. We've got two main agents in Australia. There are other ones that I won't mention, but it's basically a toss-up between povidone iodine or chlorhexidine. When assessing an antiseptic, you want to know, does it reduce bacterial counts? Do they reduce endophthalmitis in clinical practice? What concentration should we use? How long should they be on the eye? Does resistance develop? These sort of questions. So with betadine, we know that it's a very effective antiseptic. It's got a long track record. In this review we put together, we found that the concentration used varies greatly from 10% all the way down to 0.25%. And this comes back to this study from 1982 by Ruth Berkelman, who showed that if you dilute betadine, it paradoxically has a greater bactericidal effect. And it's thought to be because there's more free iodine available, and the dilute concentrations had the best effect. But in 2003, this paper from Ferguson, looking at the conjunctiva, found that 5% betadine was in fact better than 1%, and that was thought to do with the degree of bacterial load on the eye. A study from our colleagues in Melbourne, an in vitro study, showed that 5% betadine was effective, but the lower concentrations were not. You're probably getting really confused by now, but this series from Japan used just 0.25%, which is a very low concentration. No cases of endophthalmitis out of 15,000 injections. What we do know is that if you don't use antisepsis, it's just a matter of time before an eye is going to get endophthalmitis. The ideal contact time for betadine is at least 30 seconds, if not 60 seconds. And with repeated use, it looks like patients don't get development of resistance, whereas with serial antibiotic use, resistance does occur and antibiotics have largely been abandoned. A flush of antisepsis is thought to be superior to simply putting a few drops on the eye. And this paper showed that if you reapplied betadine after inserting a lid speculum, the incidence of endophthalmitis was 7-fold less. So I've been doing this in my cataract patients as well. So we know a lot about betadine. The one thing we're a little bit uncertain about is what concentration to use. And as we all know, a lot of patients, particularly those with underlying dry eye, do get post-injection discomfort and pain. The alternative is aqueous chlorhexidine. These are the two formulations readily available in Australia. They both come with a warning saying that we should not use them on the eye. It's important not to use 0.5%, which is toxic to the cornea, and they do look very similar. Up to 0.2%, however, has been shown to be safe and effective. Definitely need to not use alcohol-based chlorhexidine because, again, that's toxic to the cornea. This was a clinic-based study that showed equivalence between betadine and chlorhexidine. The important thing to see here is that they left the antiseptics on for 3 minutes, and it's thought that chlorhexidine needs a longer contact time compared with betadine. This small study from Australia showed reduced post-injection pain with chlorhexidine compared with betadine, and no difference in positive microbiological cultures. This larger randomised control study from the US basically showed the same thing. And these were patients having bilateral injections. One eye got betadine, one got chlorhexidine. And this was our series, multi-centre study from Australia. We showed that out of 40,000 injections, the rate of endophthalmitis was very low when aqueous chlorhexidine was used as the sole antisepsis. So we've got increasing knowledge regarding chlorhexidine. Like betadine, we don't really know what the best concentration is. We think the contact time is longer. The question of resistance is not as well established. So which antiseptic agent are you going to choose? Well, as the girl in the taco ad said, why don't we have both? We know that in studies outside of ophthalmology, they have shown synergy with sequential use. Chlorhexidine has an effect on the bacterial cell wall. Betadine has an effect intracellularly. That's my basic understanding anyway. So I've been doing this for a decade using chlorhexidine before the antisepsis and then povidone-iodine when doing the actual intravitreal injection. There is growing evidence outside of ophthalmology, but we need further studies in ophthalmology to look at that. And I'll just spend 30 seconds talking about drug. A French study was published in 2018 showing a significantly reduced risk of endophthalmitis in patients receiving pre-filled ranibizumab compared with drug taken from a vial. The post-injection endophthalmitis study group showed a reduced risk with pre-filled syringes, didn't meet statistical significance, but their culture positive rate was statistically significant. And again, interestingly, in the group with the pre-filled, there were no cases of oral flora-related endophthalmitis. This series was 2016 to 2017, pre-pandemic. The same group, but this was a single centre study, again showed less endophthalmitis with the pre-fills, didn't meet statistical significance. And this more recent study was a very large sort of database study, and they found no statistically significant difference between the two forms of drug. And we have largely abandoned antibiotics. I'm not going to spend much time on this, but the problems are inadequate vitreous penetration, development of resistance, and possibly an increased risk of endophthalmitis. So to summarise, we should, of course, continue wearing masks when giving injections. We need to think about that concept of the patient mask and the leakage of air up towards their eyes. We should use antisepsis. I can't tell you what concentration to use or which agent, and perhaps we should consider both. The data regarding pre-fill syringes is a little bit tricky to interpret. It certainly could be confounded by the wearing or not wearing of surgical face masks. And I don't think anybody's using antibiotics anymore. Thank you.
Thanks very much. A practical question. When, depending on either in the theatres or in the rooms, when we're doing bilateral injections, is there any evidence for doing them as two totally separate procedures with different packs, or one pack with the trays and everything on there? Do we have any evidence around which is safer?
I don't think we have any evidence, but I think most of us do them as completely separate procedures. So I'm completely OCD about this. I'll use a different little minims of binoxonate. I'll use a different little thing of chlorhexidine, a different thing of betadine, and try and really separate them out. Different little ampule of xylocaine for my subconj. So, and I'll do one, pack it all up, then do the next one and come back. Thank you.
Thank you. Our next presenter is Dr. Elsie Chan, who's a corneal surgeon based in Melbourne who is particularly dedicated to developing public hospital ophthalmology. She's going to present on emergency management of endophthalmitis, including tips for corneal patients.
Thanks very much for the introduction, and thanks to Rosie for organising this course. I'm going to talk about emergency management of endophthalmitis and tips in the cornea setting. So I've got a polling question to start off with, and for those of you who don't have the app open, that's fine if you just have a think about what answer you would select. So if you had a case of endophthalmitis presenting to you, would you, 1, do a tap and inject yourself immediately, 2, refer to your nearest hospital eye department, 3, refer to your nearest and dearest VR surgeon, or 4, panic as you realise you don't have a plan? And we'll see. I don't know if anyone's got the app open, but that's fine. Good, at least one person answered, yay. Okay. So I'm going to go back to my talk. What I'm going to do is I'm going to divide this talk up into 2. First of all, to talk about endophthalmitis in the cornea setting, and secondly, to talk about the emergency management of endophthalmitis, the protocols and procedures we have at the I&D hospital for the non-VR surgeon. Now, you might see me standing up here amongst this illustrious panel and wonder why I, as a cornea person who tries very hard not to look at the retina, is telling you about the emergency management of infections. And I think the thing to remember is that at the end of the day, these patients are going to present to us as cataract surgeons. They're not going to present to the VR surgeon immediately. So, we need to have a plan. So to start off with the very basics, reminding you all about all the protective factors we have for the eyeball. The eyelid, the tear film, the corneal epithelium, the stroma, Descemet's membrane. And so what happens when these protective factors are breached? You've of course got a risk of microbial keratitis. And earlier this year at our virtual RANSCO meeting, I spoke about managing bacterial keratitis and doing corneal scrape and starting intensive antibiotics. But which of these cases do we have to worry about endophthalmitis? Can we actually tell by the history, by the risk factors, by the clinical picture of which ones we need to consider more seriously? Because if we look at the symptoms and signs, it doesn't really help us because they're almost identical between the keratitis and endophthalmitis. The patients are in severe pain, they have conjunctival injection, corneal edema, hypopyon, and no view of the posterior segment. So out of these 4 pictures, only 2 of these patients had endophthalmitis. And you might try and guess, but it was these 2 here. But we can be reassured with what's in the literature and from our own experience at the Eye Hospital that the risk of endophthalmitis from keratitis is actually very, very low. So from this large study from Bascom Palmer of 10,000 cases of keratitis, only 0.5% of those cases also had endophthalmitis. Those patients generally had risk factors. 3/4 of them had a history of topical steroid use. Almost 2/3 had previous surgery. And interestingly, only 6% were contact lens wearers. And that's just probably because most of these contact lens wearers are in young people who have an otherwise normal, healthy host. And from a microbiology point of view, fungal keratitis was more commonly associated with endophthalmitis compared to bacterial, which isn't a huge surprise because fungal is obviously harder to treat. I haven't formally done a proper study looking at the INEA data, but in preparing today's talk, I got the data for the last 10 years of all our inpatients who had keratitis. And 2.5% of these 2008 patients also had a diagnosis of endophthalmitis. This is, of course, higher than the 0.5% from the Bascom Palmer study, mostly because it's only our more severe cases of keratitis that end up being admitted. To flip it around, to look at how many patients with endophthalmitis also had keratitis, I have Penny Allen to thank for your registry to come up with these numbers. And this is to remind you, especially the VR surgeons in the audience and the panel, don't forget to look at the cornea as well. So the risk factors, by and large, the vast majority had an ocular risk factor, such as previous keratitis, dry eyes, lid disease, rubiotic glaucoma. And 84% of them had a non-ocular risk factor, such as living in aged care, having dementia, or being immunosuppressed. So my first learning point for you is that keratitis is uncommonly associated with endophthalmitis, but do think about it in patients with ocular and non-ocular risk factors. So how do you diagnose endophthalmitis? When you have a lot of corneal edema, you have hypopyon, so you're suspecting it, but there's no view of the fundus. And of course, reaching for a B scan is a really good way of helping you diagnose endophthalmitis. And not only just doing a B scan when you first see the patient, but also repeating that B scan. Here's one patient who had a suture-related keratitis after penetrating keratoplasty, who had a hypopyon, a poor view of the fundus. Her initial B scan on presentation to our emergency was normal, but on day 5, she started to develop vitreous opacities and underwent a tap and inject. For those of you who don't have ready access to a B scan, and I am lucky, both in my public and private practices, I personally do, I think that's when you really need to think about all your risk factors and the likelihood of your patient having endophthalmitis, because they do, and you don't, you and your patient aren't somewhere where you can easily get access to a B scan, then you do have to consider about whether you perform a tap and inject immediately. So that's my second learning point. Do a B scan, repeat the B scan, and consider a tap and inject. So moving on to the second part of my talk, what do you do when this patient lands in your practice or lands in the hospital when you're on call? The most important thing is to be prepared. And at the INE Hospital, we have a door-to-needle time of 60 minutes when these patients present to our emergency department. And I know that doesn't sound like a very long time, but it actually is, because it's more than enough time for you to get yourself organised. And there are really 4 main things you need to think about in acutely managing these patients when you know that they've got when you know or suspect they have endophthalmitis. Make sure you have the drugs available to you. Make sure you have the equipment available. You can even consider in your private practices, if you don't live somewhere close where you can refer the patient, do you have a pack in the corner of your procedure room where you have things available, and making sure every year that everything remains in date. Think about where you're going to send the pathology specimen. Some of our patients from regional Victoria come with their specimen in hand because their regional ophthalmologist has done the tap and inject, and the specimen comes with them. And lastly, of course, remember to think about where you're going to refer your patient. At the Eye Hospital, we do have quite a lot of protocols and procedures around endophthalmitis and tap and inject guidelines. And for those of you who are interested in accessing them, it's on our hospital website. If you go under Health Professionals and click on our clinical practice guidelines, amongst our many guidelines is our endophthalmitis one. And here you'll find a document on the assessment and acute management of endophthalmitis. But the most important, I think the most useful page for someone like me is Appendix number 1, which goes through all the drug doses and dilutions for ceftazidime, vancomycin, dexamethasone, and if you need them, foscarnet and voriconazole. And there are tick boxes so that your assistant can mark them all off as you're performing the dilutions to make sure there are no drug errors. We also have a tap and inject protocol, which will become Appendix 2 to 5 on our clinical practice guideline once I get some time to do that, which will hopefully be after this Congress. And one of the pages goes through which drugs to inject in post-surgical versus post-traumatic versus endogenous endophthalmitis. There's another page on all the equipment required, because having it all out there before you put your gloves on is just so much easier. And finally, for those of you who are more junior in the audience or who don't do tap and injects very often, there's a step-by-step guide on how to do an aqueous tap, and a vitreous tap, and an injection. And we have each of these essential pages stuck up on our wall in our procedure room at our Eye Hospital emergency, so that are on hand, so you don't have to try and download them from somewhere and grapple with printers that often don't work. And don't forget about your pathology service. Ring ahead if it's an external provider to make sure that they know the specimen is coming and you need it processed immediately. And remember to make sure that you have arrangements for your patient to get safely to where you're going to refer them to. So from a cornea point of view, if you're going to perform a tap and inject with a patient who's at risk of a corneal perforation, do make sure you aspirate sufficient vitreous for the volume that you're going to inject for your intravitreal injection, so you don't overpressurise the eye. Check the eye with fluorescein afterwards, and be prepared to apply glue or resuture the cornea. So this photo was taken just 3 weekends ago for a patient that I did a tectonic keratoplasty on, and day 1 there was a lot of vitreous debris which we hadn't noticed prior, and so the VR fellow kindly did the tap and inject, and he said, "Elsie, you don't need to be there," but I sat there anyway because I was just paranoid that I'd need to resuture the cornea. But he did a great job. Penny, you'd be pleased to hear. And of course, don't forget to treat the keratitis according to the protocols, and you can find our hospital protocol on our clinical practice guidelines page as well. So I'd like to remind all of you who do a lot of cataracts, a lot of injections, unfortunately, as much as we use chlorhexidine 3 times over, or lots of betadine, a combination of both, intracameral antibiotics, unfortunately, a case is going to end up on your doorstep one day, and I think you just need to be prepared and have a plan in mind. And so that's my last learning point: have a plan. Thank you very much.
Thank you, Elsie. Can I ask a question about patients with microbial keratitis, and you're in that typical scenario where you're not sure whether the hypopyon is just secondary to the corneal disease or there may also be endophthalmitis, and you're umming and ahhing whether you should do a tap and inject in that moment. How much should the concern about actually introducing the corneal pathogen into the eye be a concern in actually making you not perform a tap and inject, and are there any ways to alleviate that risk?
Excellent question. Thank you very much for asking that. And I was going to deflect that question off to my VR team over here on the panel, because that is a real concern that I sometimes have, and so that's when I always pick up the phone and ring a friend. So I'm going to ring a friend right now.
I think the risk is low. At one stage we had a fellow who didn't believe that endophthalmitis ever occurred after keratitis, and in fact that's why we wrote that paper. I hope she read it. But
She still doesn't believe it.
Rosie's obviously still in contact with her. I actually think the risk is low because, you know, you're actually only going to tap and inject them when you think that the keratitis is not settling. They usually do get more pain. As you say, you do the B scan, you can demonstrate, you know, opacities on the B scan. So I think the risk of that is low.
Thank you.
Next, we'll welcome Associate Professor Matthew Simonovic. He's a Sydney-based VR surgeon and leads the Retinal Disease and Rescue Group, the SAVE Sight Institute, and he'll be talking to us about the diagnosis and organism identification.
Thank you very much. I have no relevant disclosures for this talk. So I'm going to cover the diagnosis of endophthalmitis. We've heard quite a bit already, and there's a bit of overlap between my talk and the preceding talk, so it may facilitate me getting through it a bit quicker. I'm going to talk also about the identification of causative organisms, and I'll talk about sort of traditional approaches versus modern molecular techniques. So I thought I should touch briefly upon the classification of endophthalmitis. We've heard a little bit about it so far. So, you know, traditionally the first layer of classification is endogenous versus exogenous forms of endophthalmitis. So endogenous endophthalmitis comes from either presumed hematogenous spread or from spread from neighbouring structures. Exogenous endophthalmitis is the result of penetrating trauma, be it surgical or otherwise. Arbitrarily, it's often divided into acute versus chronic endophthalmitis by a 6-week cut-off point from the point of sort of inoculation. It can be divided by the type of causative organism. I spoke previously at a RANSCO conference about fungal endophthalmitis, so I'm not going to cover that here. It's important to note that the symptoms can differ by causative organism. We've already heard that, you know, Streptococcus species is associated with severe infection, and that's in contrast to Staph epidermidis, which is associated with sort of more mild inflammation comparatively. As Rowan said earlier, we've explored our cases at Sydney Eye Hospital over a 5-year period leading up to 2017, and because of the burden of intravitreal therapy, you know, intravitreal therapy associated endophthalmitis really forms the bulk of cases that we see. And this is followed by post-cataract surgery endophthalmitis, which you can see there, and you know, more rarely things such as bleb-related and other forms of endophthalmitis. So in terms of diagnosis, I guess the most important point is that endophthalmitis, the diagnosis is a clinical diagnosis, I should say. So we don't wait for the results of a specific test, and really time is of the essence because, as we've heard already, you know, bacterial growth rates are really, really impressive in the vitreous cavity. So history can often be important, and it can give us an obvious cause, for example, a recent intravitreal injection. Sometimes it doesn't necessarily tell us a lot at all. For example, in certain cases of endogenous endophthalmitis, and it's here that you know, the help of our colleagues, say in infectious diseases, in performing a septic screen can be very, very helpful. In terms of symptoms, you know, the classic symptoms: reduced vision, pain, photophobia, swelling, redness. Looking at the EVS data, which has been referred to before, you know, blurring was the most common symptom at presentation, and that was more than 90% of patients, and this was followed by red eye pain. About a third of patients had lid swelling. In terms of the signs, they're the signs of inflammation throughout the eye. So, you know, erythema, swelling of the conjunctiva, corneal edema, hypopion, which we heard about before, AC activity, and the hallmark is involvement of the vitreous. In terms of, you know, signs about in the EVS study, more than 80% of people presented with a hypopion. So that's acute post-cataract surgery endophthalmitis, as we heard earlier on. It's really important to evaluate the eye thoroughly, always, but especially so in these patients. Sometimes their history isn't particularly flash, and we should look for a possible source of infection, such as an exposed suture or a bleb that they've not sort of confessed to. If we don't have a view, we heard it's important to do an ultrasound if you have one available. Looking for vitritis, we want to know the status of the retina, especially if we're going to go in and operate. Vitreous growth rates are impressive, as I said earlier, over the first 24 hours, and then they plateau. And typically there's a 10-fold increase over a period of 3 hours or so. Virulence factors can be important in the efficacy of intravitreal therapy. So they can increase the minimum inhibitory concentration of antibiotics by more than 1,000-fold. And Rosie will be covering the role of vitrectomy later on in such patients. Vitreous tap, as we've heard, is traditionally performed to get a microbiological diagnosis, and we do this before injection of broad-spectrum antibiotics. At Sydney Eye Hospital, around 50% of cases are culture positive, and the remainder obviously culture negative. If we look at post-intravitreal injection versus post-cataract surgery endophthalmitis, as we heard earlier on, initially at Sydney Eye Hospital, we did find an overrepresentation of Streptococcus species infection in an older study, but this was reversed, we believe, possibly because of the uptake of wearing of masks. It's important to contact the lab in cases where you think there might be an unusual causative organism, such as P. acnes in chronic post-surgical endophthalmitis. And it's because they require special culture conditions. They grow better under anaerobic conditions. What happens if you have a dry tap? You should proceed with treatment. So really the take-home message is you want to get in the antibiotics into the vitreous cavity as soon as possible. If you have a dry tap, you can try doing an AC tap if you have the experience and it's safe. But this has a lower yield than doing a vitreous tap, and it's not necessary. The other thing that I should add is that, you know, tap results, the microscopy culture and sensitivity rarely change our management. So it's possible to get a positive diagnosis using PCR even after the application of intravitreal broad-spectrum antibiotics. So a study by Shikwe and colleagues demonstrated that samples may be positive in up to 70% of people with PCR after application of intravitreal antibiotics versus 9% for traditional culture techniques. Some people advocate using a vitrector to get a sample. We don't do that in Australia. The majority of organisms, in fact, at the eye hospital over the period that I alluded to, all of the organisms were sensitive to our empirical antibiotics. So that's why I say, at least in Sydney, to date, you know, the culture results don't really change our management. This slide just really summarises with pie graphs the causative organisms for the different forms of endophthalmitis. Bleb-related endophthalmitis we'll hear about in a moment, so there is an overrepresentation of Streptococcus species infection in such cases. We heard from Penny about endogenous endophthalmitis, and I spoke about chronic postoperative endophthalmitis a little bit earlier. So in summary, endophthalmitis is a clinical diagnosis, and the most important thing is getting the intravitreal antibiotics in as soon as possible. PCR remains an option even after a dry tap and after injecting antibiotics into the eye. And the spectrum of organisms depends upon sort of the region and the country, as well as the mechanism of inoculation. Thank you.
Thanks very much. When I was training here in Brisbane as a registrar, we had a number of cases of endogenous endophthalmitis that turned out to be Pacelomyces. I'm just wondering what your thoughts are on initial presentation of a presumed endogenous endophthalmitis, whether you only give antibiotics or if there's a role for antifungals as well at the same time.
Yeah, so quite often if a lot of the patients that present with sort of post-procedural endophthalmitis sort of by default come to us. Many of the patients that present with endogenous endophthalmitis present to the uveitis team. So there is sort of a uveitis cocktail that they use on initial presentation that covers, you know, all comers, as it were. So there definitely is a role when you don't have a clue. Yeah. Good.
All right, our next presenter is Dr. George Kong, who is a hugely experienced glaucoma surgeon and researcher. He will be giving us some insights into endophthalmitis for glaucoma patients and prevention, patient education, early identification and management of endophthalmitis in glaucoma patients.
Thank you, Phoebe, and thanks to Rosie for putting together this great workshop. So endophthalmitis after glaucoma surgery is a very important disease. In glaucoma surgery, we are trying to create a channel out of the eye and remove the natural barrier that sclera has in preventing bacteria from entering the eye. And the only thing that's preventing endophthalmitis will be the conjunctiva. So it is very important in terms of the conjunctival assessments. Blebitis, as my previous, as Matthew has so indicated, is a relatively not very common condition, but it is perhaps the condition just after intravitreal injections. The incidence of blebitis is estimated to be around 0.5% over 5 years, and after trabeculectomy. And in our in the series that Penny was involved in publishing in Victoria, the endophthalmitis incidence in Victoria is around 0.4%. And in the CIGIS study, the percentage is around 1%. The common causative organisms is Streptococcus, Moraxella, and other slightly less common microorganisms, such as Enterococcus. The time to develop endophthalmitis is, on average, around 3 years after the procedure. And in terms of tube shunts, the incidence of endophthalmitis is similar to trabeculectomy, around 0.4%. But more recently, with the advent of minimal invasive procedures, such as XENs and other filtration procedures, such as Presiflow, we are seeing some reports of endophthalmitis developing subsequent to these surgeries. The clinical features of blebitis and endophthalmitis is primarily pain and reduction in vision. For blebitis, when you examine the superior conjunctiva, you can see injected conjunctiva. The fluid inside the bleb can sometimes be turbid. And there can be some anterior chamber cells of various degree. The treatment of these is generally with frequent broad-spectrum topical antibiotics, sometimes with oral antibiotic cover. And the main message is that early treatment means better prognosis. I always tell my patients that if they have had a trabeculectomy, that they need to look out for these the symptoms of pain and redness, and don't treat it like a normal conjunctivitis. And they should always have it looked at by an eye specialist. When the blebitis progresses and it becomes an endophthalmitis, there will be the additional features of hypopyon and vitritis. And sometimes you can see in the case of mixed procedures or tube shunts, you can see there can be exposure of the tube or device, and sometimes leakage from the device. treatment, of course, we've covered previously by my by other speakers. The general outcomes of bleb-related endophthalmitis is quite poor, and previous studies showed the visual outcomes can be quite, it's not very optimal, and there is not a lot of previous studies looking at how quickly in terms of treatment in visual prognosis. What are the risk factors that I recommend when you see a patient with previous glaucoma filtration surgery? What are the features to look out for to that could be potential risk for developing blebitis or endophthalmitis? They are very thin avascular blebs. If you see bleb leak, or sweating blebs, which are blebs where you put fluorescein on and you can see little small pinpoint leaks. They are not obvious, and they do need to, you do need to put the fluorescein on in order to see it properly. And if you see loose loose corneal sutures, or if you or if you have performed a bleb needling revision on the slit lamp, that can be a potential risk factor. And inferior blebs are generally not performed nowadays. In terms of tubes, the risk factors for endophthalmitis are erosion, and it's therefore very important when we as glaucoma surgeons, after the procedure, we will always have a look at the tube site to ensure that there is no erosion. In terms of the newer devices such as Zen and PreserFlow, there has been some reports on erosion of these devices, and therefore it's very important to look at the health of conjunctiva over these devices, and if there is a suggestion that they are they appear to try to be at risk of exposure, then you might need to revise the procedure earlier rather than later. Some of the preventative measures, primarily preventative measures, how do we avoid having an anterior avascular bleb? First of all, consider non-bleb forming techniques such as trans-trabecular meshwork mix rather than bleb forming mix might be an option for some patients. The Moorfield's safer surgery system was also designed to primarily prevent the formation of these anterior avascular blebs with more posterior mitomycin application, avoid excessive mitomycin application, good conjunctival closure, and avoid having thin conjunctiva over mix. In terms of secondary day prevention, if you the main message is patient education to ensure that they know about the symptoms of blebitis and endophthalmitis. If the needling is performed at the slit lamp, they should be performed with care, and I always performed it with betadine preparation. And if a bleb appears to be at risk of developing leakage, or it is a sweating bleb, it is better to repair it, and there are good ways of repairing blebs without necessarily causing a lot of trauma to the conjunctiva. In terms of tube shunts, similarly, surgical technique-wise, long scleral tracts, good covering of the tube with scleral patch or tutoplast, and good conjunctival closure. So in summary, blebitis and filtration-associated endophthalmitis can be quite devastating to the patients. And it is very important to educate patients to recognize these symptoms and not treat it just like a simple conjunctivitis. Prevention is the key. Creating a good diffuse, posteriorly draining bleb to avoid the development of blebitis and bleb-associated endophthalmitis. Thank you.
Thanks very much for that. So I have a general practice just up the road in Noosa, and a number of my patients have trabs in place running around out there. If one of them was to come in with a sweating bleb, what's the risk of that becoming endophthalmitis, and how much should I be sweating? So how soon do I need to do something if the eye's otherwise unremarkable?
Yeah. And we see a lot of that. A lot of old blebs, they have fairly thin conjunctiva and they are avascular. They're functioning, they have good pressures, and they're not in pain. So the patient thinks it's okay. But the risk is quite high if you simply leave it. But it doesn't necessarily mean that you have to repair all of those. I find that in most cases, if you give them a lot of good lubrication for the eye, that helps the bleb form a good epithelial layer over the bleb, and that can and that can be enough to treat the blebbing, the sweating bleb. But if there is persistent sweating, or if there is development of a leak, then it is better to revise the bleb. And there are sort of minimal invasive methods of revising the bleb that still allows the bleb to remain functional after the procedure.
Thank you very much. Our final presenter this afternoon is Dr. Rosie Dawkins, who is a VR surgeon based in Melbourne, has worked extensively on endophthalmitis and was the mastermind behind today's session. She's going to talk to us about the evidence for vitreoretinal surgery in endophthalmitis.
Thank you very much. Thanks, Phoebe and Chris, for chairing this session. And I'm hoping that everyone's putting questions into the app, because we're going to have a really robust discussion. I know they're coming through already. So at risk of kind of repeating myself, I'm going to start where I intend to end this talk. And that is to say, really, that it's my strong opinion that endophthalmitis isn't a vitreoretinal surgery disease. We need to think about it as a rare complication of procedures and surgery performed by most ophthalmologists. So the best outcomes come when the treating doctor educates the patients well, public or private, having a personal conversation, not relying on them to read a handout, and where antibiotics are given urgently. Actually, I was super impressed by the results of Elsie's question, but you don't need to put in a call to the VR fellow to do this. We're always happy to take the call, but we really don't want to delay things because of the replication rates of the organisms in the eye. So what is the role of VR actually in endophthalmitis? There's really 3 ways that we get involved. The first is early or immediate vitrectomy. The second is a delayed vitrectomy, so where we think the patient doesn't need an early vitrectomy, but they continue to deteriorate. And the third is later surgery to improve vision. And this is a really interesting one. We do see a lot of patients who are referred quite a good outcome from endophthalmitis treated with tap and inject, and they're referred with vitreous debris that's impairing their vision. And actually, my personal practice is to pause a bit with these patients because a really high proportion of them, that vitreous debris does dramatically improve over about the first 3 months. Epiretinal membranes, though, do also remain a concern and a limitation to visual rehabilitation. So if we talk then about immediate vitrectomy, which is really what we think about in endophthalmitis and the kind of concern, do we need to get people in for immediate vitrectomy? I guess our role as VR surgeons, as we're thinking about it, is to sterilise the eye, to remove the bacterial load, and to remove that kind of cytokine milieu that Penny was alluding to. So even if the organisms are dead, the destructive processes in the eye can continue if they're not removed, and we think that that's potentially very important. It also improves the micro yield, so either through organism identification or through PCR, which they've had quite a lot of success with in Sydney. It also allows for more rapid rehabilitation of vision, and that can be really important for both the patient and the doctor, because it's a pretty emotional experience that something that you've done has caused this problem. So what does early or immediate mean? I guess the timing in different papers has really varied. And I would actually take that a step further and say, when do we start the time course? So are we talking about time from when they present in emergency? Are we talking about time from the procedure? Are we talking about time from the onset of symptoms? And really the only one of those that we have control of is the time point when they arrive in the hospital from a VR point of view. The rest is in, a bit out of our hands. So the evidence comes from various papers which have looked at time courses from within 6 hours, within 24 hours, or even within a week. And, there are papers that talk about immediate vitrectomy, but I would say no matter how quick you think you can get a patient to theatre, you can't get them there within the 60 minutes that Elsie was talking about. And I would really urge everyone to do a tap and inject on arrival, no matter how quickly you think you can get theatre organised. You can always give antibiotics again at the end of the surgery. So when we looked at our data recently, so we looked at 3 Australian centres, the Eye and Ear Hospital in Melbourne, Sydney Eye Hospital, and Chandra looked at the cases from Charlie's in Perth. We collected 318 cases over 5 years. And what we saw, the most important thing I think that we saw in that work was that the practice of surgeons really largely remains to do an urgent vitrectomy or a vitrectomy within 24 hours in cases where vision is low. So still following kind of EVS protocol. And I would kind of turn that around a little bit, and I would say, I would urge everyone that if the patient does have PL vision or even kind of hand movements, low vision, I wouldn't sit on that patient because what we found was that the visual recovery for patients with who had early vitrectomy was greater than the patients who didn't have early vitrectomy, even though they started from a lower base. So the final visions, there was no statistical difference in the final visions, but the improvement was more with early vitrectomy. And Ben Clark's kind of words always echo in my ears, which is when you don't want to do a vitrectomy is probably when you really, really should. And a recent paper from Sarah Welch in Auckland actually had a similar finding to this. So why is the evidence for early vitrectomy so difficult to show? or for or against, really. And one of the things is the heterogeneous presentation. So we've been talking today about, patients who've had a TRAB 20 years ago, patients who've just had cataract surgery, very heterogeneous presentations and how early the patients present and their presenting vision, variability in presentation, and also, their underlying eye condition that's caused them to need to have a procedure. We also see this phenomenon in the data of biphasic visual outcomes. So we have kind of one peak of patients who have very poor vision and then a peak of patients who have, reasonable vision. And moderate visual loss isn't that prominent, and the statistical analysis is very complicated with that biphasic outcome. It's also difficult to randomise surgery and to ask surgeons to perform surgery when that's not their clinical opinion. So we do need randomised control trials, and there is one underway in the UK at present. So I guess there are also some special cases. So the fungal case, so whether you should perform a vitrectomy in fungal endophthalmitis, I think everyone knows the answer to that. But that is distinct from bacterial endogenous endophthalmitis, and really the very poor outcomes that Louis showed with gram negatives really showed that early vitrectomy is something that we really need to consider. I think a special case that we're now looking at is where a foreign body is involved. So these cases of Ozurdex-associated endophthalmitis really make us reprosecute this question. So, what are the essential steps in the vitrectomy? We need to clear the view to be able to see what we're operating on in the back of the eye. We often need to put in an AC maintainer until we can get a view of the back so that we know where our infusion line is. Scrape the cornea, clear the anterior chamber, clear the intraocular lens, sometimes remove it, and do the pars plana vitrectomy. Do we always need to get a PVD? And the answer is it's just not always possible, and it can be risky. So I think it's always our aim, but we need to be a bit circumspect sometimes. A careful search at the end is very important, but also very practically very difficult in the context of these thick membranes sometimes. And I guess the last thing that I would say is we need careful selection of tamponades. So a lot of these eyes can become hypotenuse very early after surgery, and so thinking about gas or oil, probably in preference to air, though we can sometimes leave air in some cases, and making sure that we put antibiotics in the eye again at the end after we've just removed it. So I guess the other thing that we wondered about, or that we've been wondering about, is what's the cost of all of this to the health system? Can we make a case that if you do an early vitrectomy, the patients get better faster, they get out of hospital faster? And so Will Yan did a very elegant cost-utility analysis, and what we found was in fact that the cost was to the health system was about the same, whether you did tap and inject or early vitrectomy, and so that didn't really change our management. But I guess really the main point that I wanted to make today is that whilst many of us feel that early vitrectomy can be very beneficial to patients, the evidence for that is still pretty limited, but the good evidence that we have is for early use of and early introduction of antibiotics. So really we shouldn't hesitate to get antibiotics on board in order to get patients to a centre where they can have VR surgery. Thank you.
Thank you, Rosie. We've had a lot of discussion about antibiotics in the eye with endophthalmitis, but would you be able to weigh in on the role of oral antibiotics in endophthalmitis?
Yeah, that's something that we've been having some considerable debate about. So what we know is that about 8% of endophthalmitis that present to us at the INEA are gram negatives, and that they have very poor outcomes. And so the microbiologists that we work with, when they look at the organisms, they have suggested that Cipro might be important for this group, but of course you don't know who that group are beforehand. So we do start Cipro, and then once we have the organism back, you can afford to stop the Cipro. Potentially, we certainly know that particularly in elderly, frail patients, particularly patients with renal impairment, Cipro can be a pretty tricky drug to use. We also know that Moxie covers strep better, and so we do tend to change to Moxie once we know that it's a strep. There is a movement to start Moxie first, and I don't think that's wrong. That's just not our practice based on how we're advised based on our local microbiology. So it might be the case that in different centres, local microbiological advice needs to be sought, I think.
Thank you so much. While we get prepared for our discussion time, there's been a little bit of discussion back and forward about the role of B-scan and, if you have access to one. I suppose for those of us who are in rural centres or remote clinics where you might not have access to a B-scan, a good tip is your local ED will always have a linear probe for IV access. Makes a really good substitute. Carrying on with our discussion now, we're going to have about 15 minutes of discussion time with what time we have left. Can we put it to the panel? There's a question around the role of perioperative antibiotic in cataract surgery and what to do in patients who have either penicillin or cephalosporin allergy, particularly anaphylaxis. And what's your recommendation there?
I'm happy to answer that. I was a bit concerned that I wouldn't be able to answer any questions in this endophthalmitis session because it was all vitreous-related questions. But thanks, James, for asking that question. There are guidelines that are available, written by the therapeutic guidelines. There's available online, and in general principles, in someone who's got a severe allergy to penicillin, such as anaphylaxis, airway compromise, angioedema, then you should be avoiding cephalosporins. Whereas in patients with non-severe, such as rashes, then you can give cephalosporins, and that can all be found online. I do suggest that if you're not sure, you can always, it's just to avoid yourself just not remembering these things, just have it available on the wall in your operating theatre, because we've had that for some time at the INEA Hospital, just a guideline to remind everyone. And in those situations, I personally use subconjunctival vancomycin.
Elsie, are you avoiding intracameral because of HORV?
Yeah, so our guidelines used to say to use intracameral vancomycin, but because of the uncertain risk of HORV, then we haven't when we changed over to just using subconjunctival.
Yeah, I'll do the same.
I think that's very reasonable, yeah.
Along a similar vein, we have a question around sealing the wounds at the end of phaco. And of course, we do the intracameral KEF, but is there any evidence for hydrating the wounds with KEF and creating an intrastromal depot at the end instead of using BSS?
I'm not aware of any evidence myself.
I've not seen anything in the literature. I'm not.
If there is, I haven't seen it. No.
Maybe a question for Rowan here is there a recommendation about single-use iodine prep versus the bottle of multi-use iodine prep when you're doing injections?
Not that I'm aware of it. I saw that question. We use the 100 ml bottles in our practice and have always done that. We know that those bottles can be contaminated with Pseudomonas and whatnot, but you're typically opening a bottle on the day and you're doing a number of injections, so I think the risk of contamination is very low. At my hospital where we do cataract surgery, we're not allowed to use the bottles, and we have to use the 30 ml ampules and dilute that from 10% to 5% when we do cataract surgery. But for our injection patients in our rooms, no one's telling us what we can do.
We use the bottles at the Ioneer Hospital in theatre. A new bottle's opened in the morning and it's used for the day and then it's discarded. I think there's a line that you draw between waste and, but I don't think you should be sitting on bottles for weeks.
Yeah, we did the same at the eye hospital. Yeah.
We have a question relating to rural and remote patients, and as we know, there's a lot of outreach that happens in the country. If an endophthalmitis is identified in a rural or remote area, what should steps be taken? And of course, we're all aware that rural or remote facilities may not actually have an endophthalmitis kit in the fridge. What are the panel's thoughts on the approach to that?
Well, I think that, you know, the antimicrobials may be available and you can formulate them yourself. Are you talking about the kit that's required to do the injection itself?
Yeah, let's say there's not the kit that you can mix up sitting there because you're rural or remote and you have sort of,
You don't have any,
limited
if you
stuff.
don't have anything at all, you need to get them to the closest place that does have all of that stuff available, I guess. Yeah.
I think it depends on the context. I think if it's an ophthalmologist giving injections in a rural or remote setting, then we do actually need to do that. We need to have a kit available with us when we're doing that. But if it's a patient who's gone back to another location or the ophthalmologist has left, then I think you can start Cipro at the very minimum because that's got good ocular penetration. It won't cover that many bugs, but it won't be, it's not a terrible choice. And then, transport as soon as possible, air ambulance usually.
I think we have to be proactive about having antibiotics available in practices. And are people worried about, what is it that they're worried about doing? Is it taking the vitreous sample? The most important thing is getting the most important drug, which is vancomycin, in as quickly as possible. And so if you've got one choice of drug, it's vancomycin, and most people can do, tap the anterior chamber to make the eye softer if they're worried about taking a vitreous biopsy. That would be my feeling.
Here's another question with regular intravitreal injections. For patients who are having subconjunctival anaesthetic, does that have an impact on the rate of endophthalmitis? And is there a preference that should the eye be prepped before the subconjunctival anaesthetic is placed or after?
Yeah, I'll have a crack at that. There was a paper by a chap called Tustin in 2014 in Retina that looked at this, and they found that the group of patients having subconj anaesthetic did have a significantly lower rate of endophthalmitis compared to the patients having other forms of anaesthetic. There are sort of three factors. One is that there may be an intrinsic antimicrobial effect of xylocaine. The second is that when you have a bleb, perhaps you are diluting bacteria. And the third is it may reduce the chance of having a vitreous wick afterwards. The other part of the question was, should you give some sort of antisepsis before the subconj? I think you should. There hasn't been much published on this, but you certainly could inoculate the subconjunctival space, and that's why what I've always done is used Chlorhex before that, because I know it's sort of a bit kinder on the eye. And also that concept of synergy. So I use the betadine afterwards.
Do you think that by putting the subconj in, you actually also increase the time between that first sort of antisepsis and the actual intravitreal injection, and so that maybe you're, deliberately allowing the betadine or the chlorhexidine to be on the eye for longer?
And that was the fourth point that I didn't mention. Yes, definitely.
Okay, well, that looks like we're out of time. Thank you very much for the panel, for your expertise, and thank you for the audience for all of your questions. We'll put our hands together for the panel. We'll finish today's session. Thank you.
Yeah.